Hi everybody, I am Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia. You are on Dr. Y channel. So, Crohn disease. Today's topic is a Crohn disease, original enteritis, Granulomatous Ileitis or Granulomatous Ileocolitis. So, Crohn disease is a chronic transmural inflammatory disease, bowel disease of course, that usually affects the distal ileum and colon and may occur in any part of the gastrointestinal tract. Symptoms include diarrhea and abdominal pain, abscesses, internal and external fistulas, and bowel obstruction may arise. Extraintestinal symptoms, particularly arthritis, may occur. Diagnosis is by colonoscopy and imaging studies. Treatment is with 5-amino salicylic acid, aminosalicylate acid, corticosteroids, immunomodulators, anti-cytokines,
Antiketones,
antibiotics, and often surgery. Concerning pathophysiology, Crohn disease being with crypt inflammation and abscess which progress to tinifocal aptoid ulcers. Aptoid ulcers. The mucosal lesions may develop into deep longitudinal and transverse ulcers with intervening mucosal edema, creating a characteristic cobblestone appearance to the bowel. So, transmural spread of inflammation leads to lymphedema and thickening of the bowel wall and mesentery. Mesenteric fat typically extends on the serosal surface of the bowel. Mesenteric lymph nodes often enlarge. Extent inflammatory may result in hypertrophy of the muscularis mucosa, fibrosis, and structure formation, which can lead to bowel obstruction. So anyway, this is, my dear friends, autoimmune disorder. Abscesses are common and fistulas often penetrate into adjoining structures, including other loops of bowel, the bladder or psoas muscle. Fistulas may even extend to the skin of the anterior abdomen or flanks. Independently of intra-abdominal disease activity, perianal fistulas and abscesses occur in 25 to 33% of cases. These complications are frequently the most troublesome aspects of the Crohn disease. Non-caseating granulomas. Non-caseating granulomas can occur in lymph nodes, peritoneum, the liver, and all layers of the bowel wall. Although pathognomonic when present, granulomas are not detected in about half of patients with Crohn disease. The presence of granulomas doesn't seem to be related to the clinical course. Segments of diseased bowel are sharply demarcated from adjacent normal bowel, called skip areas. Hence the name regional enteritis. Okay? So segments of diseased bowel are sharply demarcated from adjacent normal bowel, called skip areas. Hence the name regional enteritis. About 35% of Crohn disease cause involve the ileum alone, ileitis. About 45% involve the ileum and colon, ileocolitis, with a predilection for the right side of the colon. About 20% involve the colon alone, granulomatous colitis, most of which, unlike ulcerative colitis, spare the rectum. Spares the rectum. Occasionally, the entire small bowel is involved. Granulomatous
Granulomatous.
Okay. The stomach, duodenum, or esophagus is clinically involved only rarely. Although microscopic evidence of disease is often detectable in the gastric antrum, especially in younger patients, in the absence of surgical intervention, the disease almost never extends into areas of small bowel that are not involved at first diagnosis. Crohn disease is categorized into three principal patterns: primarily inflammatory, which after several years commonly evolves into primarily stenotic or obstructing, or primarily penetrating or fistulizing. These different clinical patterns dictate different therapeutic approaches management. Some genetic studies suggest a molecular basis for this classification. This is an increased risk of cancer in affected small bowel segments. Patients with colonic involvement have a long-term risk of colorectal cancer equal to that of ulcerative colitis, given the same extent and duration of disease. Chronic malabsorption may cause nutritional deficiency, particularly of vitamins D and B12. Toxic megacolon is a rare complication of colonic Crohn disease. It's a clinical syndrome of ileus accompanied by radiographic evidence of colonic dilation. Many cases must be treated aggressively with surgical intervention. About symptoms and signs of Crohn disease. The most common initial manifestation of Crohn disease is chronic diarrhea with abdominal pain, fever, anorexia, and weight loss. Anorexia, right?
Anorexia.
The abdomen is tender and mass of fullness may be palpable. Gross rectal bleeding is unusual except in isolated colonic disease, which may manifest similarly to ulcerative colitis. Some patients present with an acute abdomen that simulates acute appendicitis or interstitial obstruction. About 33%, one-third of patients have perianal disease, especially fissures and fistulas, which is sometimes the most prominent or even initial complaint. In children, extraintestinal manifestations frequently predominate over gastrointestinal symptoms. Arthritis, fever or unknown origin, anemia or growth retardation may be a presenting symptom, whereas abdominal pain or diarrhea may be absent. With recurrent disease, symptoms vary. Pain is most common and occurs with both simple recurrence and abscess formation. Patients with severe flare-up or abscess are likely to have marked tenderness, gardening, rebound, and general toxic appearance. Stenotic segments may cause bowel obstruction with colicky pain, distension, obstipation, and vomiting. Adhesions from previous surgery may also cause bowel obstruction, which begins rapidly without the prodrome of fever, pain, and malaise typical of obstruction due to Crohn disease flare-up. because it's very important to understand. So once again, adhesions from previous surgery may also cause bowel obstruction, which begins rapidly without prodrome of fever, pain and malaise typical of obstruction due to Crohn disease flare-up. So an enterovesical fistula, enterovesical, sorry.
Enterovesical.
Yeah, an enterovesical fistula fistula may produce air bubbles in the urine, pneumaturia. And draining cutaneous fistulas may occur. Free perforation into the peritoneal cavity is unusual. So chronic disease causes a variety of systemic symptoms, including fever, weight loss, malnutrition, and other extraintestinal manifestation of inflammatory bowel disease. Concerning diagnosis, so barium X-rays of the small bowel, abdominal computer tomography, conventional or computer tomography, enterography. Sometimes barium enema, magnetic resonance, enterography, upper endoscopy, colonoscopy, and or video capsule endoscopy. Crohn disease should be suspected in patient with inflammatory or obstructive symptoms or in patient without prominent gastrointestinal symptoms but with perianal fistulas or abscess or with otherwise unexplained arthritis. Arthritis, erythema nodosum, fever, anemia, or in child stunted growth. A family history of Crohn disease also increases the index of suspicion. Similar symptoms and signs, for example, abdominal pain, diarrhea, may be caused by other gastrointestinal disorders, particularly ulcerative colitis. Differentiation from ulcerative colitis may be an issue in 20% of cases in which Crohn disease is confined to the colon. However, because treatment is similar, this distinction is critical only when surgery or experimental therapy is contemplated. Patients presenting with an acute abdomen, either initially or during a relapse, should have flat or upright abdominal X-rays and abdominal computer tomography scan. These studies may show obstruction, abscess of fistulas, and other possible causes of an acute abdomen, for example, appendicitis. Ultrasonography may better delineate gynecologic pathology in women with lower abdominal and pelvic pain. If initial presentation is less acute, an upper gastrointestinal series with smaller ball of follow-through and spot films of the terminal ileum is preferred over conventional computer tomography. However, newer techniques of computer tomography and magnetic resonance enterography with combined higher resolution computer tomography and magnetic resonance imaging with large volumes of ingested contrast are becoming the procedures of choice in some beautiful centers. These imaging studies are virtually diagnostic if they show characteristic strictures of fistulas with accompanying separation of bowel loops. But if findings are questionable, computer tomography and enteroclysis computer tomography enteroclysis or video capsule enteroscopy may show superficial apoptosis and linear ulcers. Barium enema X-ray may be used if symptoms seem predominantly colonic, for example diarrhea, and may show reflux of barium into the terminal ileum with irregularity, nodularity, stiffness, with wall thickening, and a narrowed lumen. Differential diagnoses in patients with similar X-ray findings include cancer of the cecum, ileal carcinoid, lymphoma, systemic vasculitis, radiation enteritis, ileocecal tuberculosis, and amoeboma. 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 Okay, let it be amoeboma. In typical cases, for example, predominantly diarrhea with minimal pain, evaluation is similar to suspected ulcerative colitis, with colonoscopy, including biopsy, sampling for enteric pathogens, and when possible, visualization of the terminal ileum. Upper gastrointestinal endoscopy may identify subtle gastroduodenal involvement even in the absence of upper gastrointestinal symptoms. Laboratory tests should be done to screen for anemia, hypoalbuminemia, and electrolyte abnormalities.
Electrolyte.
Yeah, electrolyte abnormalities.
Electrolyte abnormalities.
Abnormalities. Liver tests should be done. Elevated alkaline phosphatase and gamma-glutamyl transpeptidase levels in patients with major colonic involvement suggest possible primary sclerosing cholangitis. Yeah, cholangitis. Right? Cholangitis. Cholangitis. Okay, let it be cholangitis. Leukocytosis or increased level of acute phase reactants, for example, erythrocyte sedimentation rate, erythrocyte, of course, erythrocyte sedimentation rate, C-reactive protein, and are non-specific, but may be used serially to monitor disease activity. To detect nutritional deficiencies, levels of vitamin D and B12 should be checked every 1 to 2 years. Additional laboratory measurements, such as levels of water-soluble vitamins, folic acid and niacin, fat-soluble vitamins A, D, E, and K, and minerals, zinc, selenium, selenium and copper may be checked when deficiencies are suspected. All patients with inflammatory bowel disease, whether male or female, young or old, should have their bone mineral density monitored, usually by dual energy X-ray absorptional DXA scan. Perinuclear antineutrophil cytoplasmic antibodies are present in 60 to 70% of patients with ulcerative colitis and in only 5 to 20% of patients with Crohn disease. And so, anti-Saccharomyces cerevisiae antibodies are relatively specific for Crohn disease. Oof. Okay.
Anti-Saccharomyces cerevisiae antibodies
are relatively specific for Crohn disease. However, these tests do not reliably separate the two diseases, and they are not recommended for routine diagnosis. Additional antibodies such as anti-OMPC and anti-CBR1 are now available, but the clinical value of these supplementary tests is uncertain. Some studies suggest that high titers of these antibodies have adverse prognostic implications. Actually, prognosis for Crohn disease, established Crohn disease, is rarely cured but it's characterized by intermittent exacerbations and remissions. Some patients have severe disease with frequent debilitating periods of pain. Debilitating periods of pain. However, with judicious medical therapy, and where appropriate surgical therapy, most patients function well and adapt successfully. Disease-related mortality is very low. Gastrointestinal cancer, including cancer of the colon and small bowel, is the leading cause of excess Crohn disease-related mortality. Thromboembolic complications, especially during active Crohn colitis, also may cause death. About 10% of people are disabled by Crohn disease and the complications it causes. So about treatments: loperamide and antispasmodics for symptom relief, and
5-aminosalicylic acid, 5-ASA, or antibiotics.
Other drugs depending on symptoms and severity, for example, immunomodulating drugs and biological agents, sometimes surgery. Details of specific drugs you can find in American College Gastroenterology Guidelines. So today's topic is not for that. Cramps and diarrhea may be relieved by oral administration of loperamide 2 to 4 mg or antispasmodic drugs up to 4 times a day, ideally before meals. Such symptomatic treatment is safe except in cases of severe acute Crohn colitis, which may progress to toxic colitis as an ulcerative colitis. Hydrophilic muciloids, for example, methylcellulose or psyllium preparations, sometimes help prevent anal irritation by increasing stool firmnesses. Dietary roughage, Dietary roughage is to be avoided in restricting diseases or active colonic inflammations. Routine health maintenance measures, for example immunizations, cancer screening should be emphasized. Mild to moderate cases. This category included ambulatory patients who have tolerate oral intake and have no signs of toxicity, tenderness, mass, or obstruction. Mesalamine, 5-ACA. Mesalamine, but I'm not a mesalamine, like a gladiator name. Mesalamine is commonly used at first-line treatment. Pentasa is a favorite for small bowel disease, and Azacol is a favorite for distal, ileal, and colonic disease. However, the benefits of any 5-ACA, for example, mesalamine drugs for small bowel Crohn disease, are modest, and many experts advocate not using it in a small bowel Crohn disease. Antibiotics are considered the first-line agent, but some clinicians, or they may be reserved for patients not responding to 4 weeks for 5-ACA, mesalamine, for example. Their use is strictly empiric. With any antibiotics use is strictly empiric. With any of these drugs, 8 to 16 weeks of treatment may be required. Responders should receive maintenance therapy. Concerning moderate to severe disease, patients with fistulas or abscesses but with significant pain, tenderness, fever, or vomiting, or those who have not responded to treatment for mild disease often have rapid relief of symptoms when given corticosteroids, either oral or parenteral. Oral prednisone may act more rapidly and reliably than our oral budesonide. Budesonide, but budesonide has somewhat fewer adverse effects, and it's considered the corticosteroid of choice in many centers, especially in Europe. Patients who do not respond rapidly to corticosteroids or those who cannot be tapered with a few weeks must not be maintained on these drugs and require different therapy. An anti-metabolite or anti-tumor necrosis factor agents or a combination of both can be used as second-line therapy after corticosteroids and even as first-line therapy in preference to corticosteroids. These drugs, guided by measurements of drug and antibody levels, achieve clinical success in most cases. When these lines of treatment fall in patients for whom surgery is not feasible or appropriate, newer biological drugs, including anti-integrins or anti-interleukin 12-23 antibody, can be used. For example, ustekinumab. Ustekinumab can be used. Furthermore, other biologic agents are emerging rapidly. Obstruction is managed initially with nasogastric suction, and intravenous fluids. Obstruction due to uncomplicated Crohn disease should resolve within a few days and therefore doesn't require either specific anti-inflammatory therapy or parenteral enutrition. Absence of prompt response, however, indicates a complication or another etiology and requires immediate surgery. Patients with toxic appearance, high fever, persistent vomiting, rebound or tender or palpable mass must be hospitalized for administration of intravenous fluids or antibiotics. Abscesses must be drained either percutaneous or surgically. Intravenous corticosteroids or biological agents should be given only when infection has been ruled out or controlled. If there is no response to corticosteroids and antibiotics within 5 to 7 days, surgery is usually indicated. Fistulas. Perinatal fistulas are treated initially with metronidazole and ciprofloxacin. Patients who do not respond in 3 to 4 weeks may receive an immunomodulator, for example, azathioprine, with or without any induction regimen of infliximab or adalimumab for more rapid response. Anti-TNF therapy can also be used alone. Cyclosporine or tacrolimus is an alternative, but fistulas often relapse after treatment. Yeah, it happened. Endoscopic ultrasound, guided placement or fibrin glue, or use a cetone drain, a piece of suture material temporarily left in the fistula to allow it to drain, may help some patients with more complex or refractory perianal fistulas. Severe refractory perianal fistulas may require temporary diverting colostomy, but almost invariably recur after reconnection. Hence, the diversion is more appropriately considered a preparation for definitive surgery or at best an adjunct to infliximab or adalimumab rather than a primary treatment. So concerning maintenance therapy, patients who require only 5-ACA or antibiotics to achieve remission of Crohn disease can be maintained on that drug. Patients requiring acute treatment with corticosteroids or anti-TNF agents typically require azathioprine, 6-mecatopurin, methotrexate, and anti-TNF therapy or combination therapy for maintenance. Many, if not most, patients brought into remission with anti-TNF agent will require escalation of dose of shortening of the treatment intervals within a year or two. Systemically active corticosteroids are neither safe nor effective for long-term maintenance, although budesonide has been shown to delay relapse with fewer adverse effects. Patients who respond to anti-TNF therapy for acute disease but who are not well maintained or antimetabolites. Antimetabolites may stay in remission with repeat doses of anti-TNF agents. Monitoring during remission can be done by following symptoms and doing blood tests, and does not require routine X-rays or colonoscopy, other than regular surveillance for dysplasia after 7 to 8 years of disease. Even though about 70% of patients ultimately require an operation, surgery for Crohn disease is often done reluctantly. It's best reserved for recurrent intestinal obstruction or intractable fistulas or abscesses. Resection of the involved bowel may ameliorate symptoms but doesn't cure the disease, of course, which is likely to recur even after resection of its clinically apparent lesions. I don't understand why my colleagues don't talk about problem of autoimmune disorder or immune disorder at all. Very good guideline, but no one word about autoimmune problems. The recurrent rate defined by endoscopic lesions as the anastomotic recite is more than 70% at 1 year and more than 55. No, 85, sorry. So more than 70% in 1 year and more than 85% at 3 years. So 70 in 1 year, so 85 more than at 3 years. Defined by clinical symptoms, the recurrence rate is about 25 to 30% at 3 years and 40 to 50% at 5 years. Unfortunately, further surgery is required in nearly half of cases. However, recurrence rates seem to be reduced by early postoperative prophylaxis with 6-mercaptopurine mercaptopurine maybe, huh?
6-mercaptopurine
or azatioprine,
azathioprin,
metronidazole or infliximab. Moreover, when surgery is done for appropriate indications, almost all patients have improved quality of life. Because smoking increases the risk of recurrence, especially in women, smoking cessation should be encouraged. 6 key points. So Crohn disease, key points, my friends, typically affects the ileum or colon but spares the rectum, which is invariably affected in ulcerative colitis. Intermittent areas of diseased bowel are sharply demarcated from adjacent normal bowel, called skip areas. Symptoms primarily involve episodic diarrhea and abdominal pain. Gastrointestinal bleeding is rare. Complications include abdominal abscess and enterocutaneous fistulas. Treat mild to moderate disease with 5-aminosalicic acid or antibiotics. But no words about probiotics and prebiotics. I don't understand why. No, up to you. Guideline is a guideline. Maybe they know, not maybe. Sure, they know more than me. Treat severe disease with corticosteroids and sometimes immunomodulators or biologic. About 70% of patients ultimately require an operation, typically for recurrent intestinal obstruction, intractable fistulas, or abscesses. So that's all concerning guidelines of my friends concerning Crohn disease. Thanks for your attention, my friends. Please don't forget to make your subscription to our channel, Dr. Y, and primarily don't forget about your donations. Your donates are absolutely primordial for us, because due to your donations, our channel still exists. So thanks for your attention. God bless you.